Nursing Solutions, Improving Caregiver Strain, the Science, and a Model Intervention. As we know, Parkinson's disease is a chronic and progressive disorder. For many people with Parkinson's, it spans years and even decades. As the disease continues, there's a gradual loss of autonomy for the patient, and this certainly impacts the caregivers and family of the patient as well as the patient, him or herself. Caregivers can experience and may experience a negative impact on their quality of life over time. By recognizing the multitude of caregiver positive and negative factors, nurses and other healthcare providers can better assess for caregiver strain and help caregivers to develop healthy coping strategies. Our objectives for today are to first discuss a clinically useful research framework to help family caregivers of people with Parkinson's disease. Also, to recognize factors and variables that may influence caregiver strain. We will then contemplate interventions that may assist caregivers in coping with their role and become familiar with the use of PhotoVoice, an intervention to help caregivers discuss difficult topics. I'd like to introduce our first speaker. Julie Carter is a nurse practitioner and professor of neurology at Oregon Health Sciences University. She is one of the original founders of the Parkinson Center of Oregon and joined Oregon Health Science University Department of Neurology in 1979. Julie has dedicated her career to improving the lives of people with Parkinson's disease and their families. In addition to her clinical work with patients and families, Julie has been instrumental in the creation of the annual Patient and Family Symposium, the Family Caregivers Series, the Young People with Parkinson's Symposium, the Newly Diagnosed Program, and the Strive to Thrive for Self-Management. Most recently, Julie has devoted her efforts to establishing a palliative care program for Parkinson's disease. Julie's research expertise serves her as one of the original members of the Parkinson's Study Group. She has published extensively on family caregiving and Parkinson's. In 2016, Julie received the Distinguished Contribution to the Community Award by the World Parkinson's Disease Coalition at the World Parkinson's Congress. Congratulations and welcome, Julie.
Thank you, Gwen. It's so nice to be here and be able to talk to all of you, even though I'd love to be seeing you. But I'm very pleased to have an opportunity to share some of my information with you. One disclaimer, when Gwen invited me to talk about the science behind caregiver strain, I recognize that for those of you who are out there who are hands-on clinicians and also perhaps caregivers of somebody with Parkinson's disease, that might sound a bit distancing. But I want you to know that my goal is really to just take the science or what we know and apply it in a very clinically relevant way. So Gwen has already discussed my objectives, which I will skip that. And I'd like to start out with a bit of a philosophical question, which I feel like should be discussed, which are families invisible patients? As clinicians, so much of what we do is through our families. We rely on them for assessment, we rely on them for their knowledge, and also carrying out many of the things we decide in terms of a plan of care. One very interesting statistic that I think would be worth sharing, and this now is across all caregivers in the U.S., not just for Parkinson's disease. But a 2013 statistic was that caregivers provide 37 billion hours of care with an estimated economic value, and this is paying them like $12 an hour, which is nothing, of $470 billion a year. That is greater than many large organizations bring in a year. So their economic benefit, purely from an economic point of view, is really quite staggering. At the same time, at a more humanistic level, we know that the role of caregiving, the job of caregiving, has its own toll. And the literature is well substantiated in the recognition that there are many negative outcomes. Greenwell et al., if you're interested in this article, is a beautiful review of the caregiving literature in Parkinson's disease. And we know without a doubt that there's a decline in mental health, physical health, and quality of life. So I think that hopefully that really suggests that as clinicians, we need to think of caregivers not only as part of the healthcare delivery system, but also as part of our unit of care when we deliver care to our patients. I now want to define caregiver strain because it's important to start with a common understanding, which is my definition is it's the perception of emotional, social, financial, physical, and spiritual difficulty in performing the caregiver role. And perception is a very important word because we all know of caregivers who are doing a lot and seem to be coping pretty well, not perceiving that they have a lot of strain, where we have another caregiver who is doing similar kinds of things and feels very strained and under a great deal of stress. I want to show you some old research that I've done with my colleagues, but I show it because it really, in a glance, suggests several things. First of all, to orient you to the graph, the horizontal slide represents, we looked at a variety of types of strain. We looked at worry, tension, frustration from communication, strain from direct care, mismatched expectations, economic burden, lack of resources like energy type resources, and global strain. And we looked at different stages of disease. We actually followed these 300 caregivers for 10 years. And these two lines are early stage, these two lines are middle stage, and the blue line is late stage. At a glance, you can see two things. One, that even in early stage disease, there is strain. The second point is that strain accumulates as the disease progresses, which of course is no surprise to any of us. But the third thing that you don't see as readily, because these points are all mean scores and the error bar is not present. But at each of these points, there's tremendous range around the mean. So what that says to us is that some caregivers doing the same amount of work are really not experiencing, or they don't perceive the same amount of strain as another person. So the question becomes, why is that? And this is where I think sometimes it's useful to use what we call as a research framework. And there are a number of research frameworks. One of the ones that I think applies well to caregivers, I also think it's very straightforward, is the transactional model of stress and coping. And basically what this framework says is that strain is an imbalance between demands and resources. And that occurs when demands exceed one's perceived ability to cope. So when you think about it, there are so many variables that go into an individual caregiver. And so there are demands, and then there are resources. And I call those risk factors and protective factors. And we know from the literature that there are some very well-substantiated risk factors and some very well-substantiated protective factors. And this becomes very important when we think about how to help our caregivers. So let me just review a few a few of the predictors or risk factors that we know from the literature. First of all, the symptoms of the person with Parkinson's disease. We know that the non-motor symptoms, particularly the neuropsychiatric symptoms, predict more strain than motor symptoms, and specifically hallucinations and paranoia, and followed by depression. Within motor factors, we know that falls are a greater predictor of strain than the other motor factors of fluctuations and dyskinesia. And then within the caregiver themselves, there are a number of things we know for sure. One is that younger caregivers experience more strain than older. When we think about demographics, caregivers who actually females experience more strain than males, and I'll mention a few more of these when as the talk goes on. In terms of psychiatric symptoms, we know that depression predicts more strain. Depression of the caregiver predicts more strain. And then personality traits. One of the, in our group has looked at both optimism and pessimism. They're actually not on a continuum, but two different scales. And pessimism will predict more strain. I've put in DBS because I think it's a very important awareness heightening comment, because it's easy to assume that if a person with PD has DBS, that will translate into decreased strain for their family. And in fact, that is not the case. Mosley and Marsh published some interesting work, and one of the things they noted that as we all know, DBS does not improve the non-motor features. In general, it does not. And those continue to progress, and those are the ones that predict more strain. So just a word of caution in your DBS population. Now, protective factors. We know that social support, perceived network of help, and I say perceived again because some people have a lot of support but don't perceive it as support. In personality traits, the ones that are protective are a sense of competency or self-efficacy and optimism, and also a sense of meaning, which becomes a broad realm of spirituality. The other protectors are good physical health and good mental health. The quality of the partnership, people who feel very close to their spouse, even though mutuality declines as the disease progresses, the underlying pre-diagnosis mutuality is truly protective if it's positive. And then this concept of preparedness, both as a sort of a competency preparedness as well as a skill-based preparedness, both of those are protective. And I want you to really look at this slide because these factors are all malleable for the most part. Mutuality, maybe not so much. Mental and physical health can be less so, but the other things you can intervene with. And by looking at an individual caregiver, assessing them, and understanding what their risk factors as well as their protective factors can be very helpful in thinking about interventions. So first, what about assessment? This is a longer talk than my 20 minutes, but I would like to just put three categories of assessment out there. there's sort of the assessment of strain or the situation of the caregiver, which when you're thinking about you're thinking about what social network they have. You might be thinking about the symptoms of the care receiver, and then also just their perception of strain. Assessment of capacity are some of those demographic things that I mentioned. Their age, their other care demands. Are they working outside the home? Are they taking care of elderly parents? Do they have children in their home? Are they male or female? Do they have depression? Do they have a lot of their own comorbidities? And then the assessment of preparedness, how competent they are, and what skills do they need. And I want to bring up one other thing. We often think of, we forget sometimes to ask caregivers or take into consideration their own values. As an example, some caregivers are not prepared emotionally or value-wise to help their partner with toileting. And so just, again, a comment of awareness to think about not only do they need training in an area or not, but what is this something they want to do from their own value-based personality. So then moving on to interventions, what do we know from research? First of all, I will say that the literature for interventions in Parkinson's disease is really very limited. And it doesn't mean that they don't work, but we don't have a lot of positive outcomes in our interventions. And looking at the dementia literature, I just wanted to pose what I think are potentially some reasons for this. One is that still many of the interventions are educationally based, and we know in general that that psychoeducational interventions are the ones that show the best outcomes. So basically, teaching caregivers skills as well as knowledge becomes a much more powerful intervention. The other thing I think is that because we've just talked about how multifactorial caregiving variables are, that sometimes interventions don't address multiple stressors. And when you measure the outcomes, we don't end up with a positive result simply because we're not measuring the number of stressors that could be affected. And then also, one size doesn't fit all. And that is why we should try to match the caregiver's agenda with the actual intervention. And then finally, I think we have less knowledge about sort of the sufficient amount and duration of an intervention to achieve the best outcome. So when we think about outcomes, again, I want to take you back to that transactional model of stress and coping and think about improving resources, that balance between resources and demands. And many of the resources that are really useful to capitalize on in family caregiving are improving competence, improving preparedness, improving information, and also improving attitude. And Peter Hudson, who is a senior investigator in caregiver strain from Australia, has really written some beautiful things about this whole concept of interventions in caregiver, especially in the palliative care, later stage disease, across all caregiving. So if you're interested, that resource is there. A few interventions that have been cited in the literature for Parkinson's disease, one is cognitive behavioral therapy. And Roseanne Dobson has been sort of a leader in this field, helping caregivers reframe some of their assumptions and negative thoughts, which affects the way they behave and the way they I feel it can be very powerful. It is time intensive, and most of the work that's been done has been done on an individual basis, and therefore makes it expensive, but very useful at an individual level. A Campo and et al. Put together a standardized patient education program that was delivered to patients in a group and then separately to caregivers in a group. And this was done in Europe across several countries and did show positive results in terms of the mental health of family caregivers. And then finally, a more universally a more universal program, the Stanford Chronic Disease Self-Management Program, which is a standardized program, a train-the-trainer model by Kate Lorig. We modeled our Strive to Thrive. We utilized the Stanford Chronic Disease Self-Management Program and delivered it to couples of people with Parkinson's disease. It was a 6-week program, 2 hours for each session, and that program then we added a 7th week. So we retained the fidelity of the Stanford program, but added a Parkinson's segment, and we're able to take the principles and skills that we learned, or the audience learned, and apply them to Parkinson's disease. We also gathered some data on our couples, and we're just analyzing that now, and I'm really pleased to say that the results are very powerful, more powerful than individuals alone. And one of those next steps in, I think, Parkinson's disease interventions, which is really approaching the dyad as an intervention unit rather than the individual patient and the individual caregiver. So with that, I hope that these take-home messages were achieved, that you truly understand that strain occurs at all stages of disease. It's heterogeneous, making interventions complex, that it's so important to assess caregivers thinking about risks and resources, and that when we refer caregivers for interventions, we really refer them to a skill-based intervention because it holds the most promise. Thank you very much.
Thank you, Julie. That was a wonderful presentation. Julie will be available to answer questions after our second speaker. Please note that questions can be submitted by clicking in the text messaging box in the bottom left corner. Type in your questions and then hit the send button. We will answer questions after our next speaker. So at this point, I would like to introduce our next speaker. Our next speaker is Joyce Bredesen, and Joyce is an associate professor of nursing at the Metropolitan State University School of Nursing in St. Paul, Minnesota. She teaches undergraduate and graduate level public health nursing theory and clinicals. Her research interests includes PhotoVoice and working with vulnerable populations. She has done presentations on her work internationally. Joyce devoted her sabbatical to working with Parkinson's disease patients, families, caregivers, and support groups with her work on PhotoVoice, and presented her work at the 2013 and the 2016 World Parkinson's Congresses. Joyce is a 2013 scholar of the Edmund J. Safra Visiting Nurse Faculty Program at the Parkinson's Foundation. Welcome, Joyce.
Thanks, Gwen. Good morning or afternoon, wherever you're at. And thank you, Julie, for the wonderful research and work you've done with Parkinson's disease. Today, I'd like to share information about a wonderful tool called PhotoVoice that can be utilized to bring about more in-depth discussion and assist with a better understanding of what people who are living with Parkinson's disease are facing in their everyday life realities. Parkinson's disease is near and dear to my heart, as my father passed away after struggling for 20 years, Parkinson's disease. So that's the primary reason I searched for a tool that would help people who are living with Parkinson's disease. And Julia shared about negative outcomes being a decline for the caregiver in mental health, physical health, and quality of life. And I can attest to that because I've seen my mom's health after 2 years of my dad being gone, that it's drastically improved. She's walking better, she's sleeping better, she's even asking to go on a trip. She's 85 years old, so it's really interesting what that caregiving role has done for her along the way. So first, I'd like to share a little bit about the background on PhotoVoice. It's a participatory research methodology that can be used with various populations in an assessment process and intervention, as well as an evaluation tool. The intended outcomes of PhotoVoice are to empower the participants, increase community awareness, and to promote dialogue that can bring about change and a better understanding of the issues that are being addressed. PhotoVoice has 3 main goals. The first goal is to help those who are often unheard gain a voice, enabling them to record and reflect on their life experiences, both positive and negative. The second goal is to encourage critical consciousness through choosing, discussing, and reflecting on the pictures that they've taken that will help them come to a clearer understanding of their circumstances and the economic, social, psychological, and other forces that shape them. And the third goal is to bring about change that will improve conditions and enhance lives by reaching and influencing those around them who can affect change. So the concept of PhotoVoice has existed for many years. And I'm not sure why this is moving forward. Sorry about that. But much of the theoretical background of current programs comes from the work of Dr. Carolyn Wang and Marianne Burris in the early 1990s. And as you can see from the slide, so what is PhotoVoice? It is a technique that utilizes photographs to tell people's stories of their reality. So it's quite simple. And as you know, the saying, pictures say 1,000 words. Visual images and the meanings of those images is a very powerful method to explore the participants' realities and perspectives of their everyday world. So PhotoVoice is a process in which people, usually those with limited power due to poverty, language barriers, race, class, ethnicity, gender, culture, or other circumstances, can use video or photos to capture aspects of their environment and experiences and then share them with others. The pictures can then be used, usually with captions composed by the photographers, to bring the realities of their life experiences to the forefront and hopefully spur change to improve those conditions. Research that has been done with utilizing the PhotoVoice methodology shows that it is a powerful tool to elicit in-depth discussion. So in this process, cameras are used by the participants to take pictures of their world through their eyes and then tell the meaning and story behind the pictures that they have taken. Generally speaking, the PhotoVoice process is set up as 2 to 3 meetings. The first meeting is used to go over the project, the use of the camera, ethical issues related to using the camera in public settings, and also reviewing the consent forms for the project. The second meeting is related to developing the pictures and discussing the process and how it went for the participants. And the third meeting is to review the pictures, discuss what the pictures mean to the participant who took the pictures. So I've utilized PhotoVoice working with youth, homeless families, Parkinson's disease care partners, as well as recently within Parkinson's support groups as an intervention. Themes were identified in each area, as well as statements of reflections on the use of PhotoVoice. Through this process, I have met with individuals to discuss the pictures and tell their stories, as well as meeting within group settings, such as the Parkinson's disease support groups. Within the group settings, the participants have helped to identify the themes. Using PhotoVoice as I did as an intervention within a support group setting has not been done, or at least I've not found literature regarding it. The goal was to see if PhotoVoice could be used as a therapeutic intervention within the setting that could lead to bringing about a deeper, more in-depth discussion, as well as allowing the participants to explore and express their feelings in their daily walk with Parkinson's disease, which ultimately might help with coping and also in the healing process. I worked with 12 support groups throughout Minnesota with approximately 150 participants. The participants were both those who had Parkinson's disease and the care partners and their family members. And I think it's really important to note that the rural areas, at least what I found in Minnesota, was that they have very limited resources, both financially and also just lack of access to many of the wonderful resources that are out there. And what I did notice with the support groups is that many couples attended together. So when using PhotoVoice, it also gives the participants the opportunity to share their pictures and stories with the community or the public to bring about more awareness of the issue, as well as, of course, to hopefully impact change. So one example would be that a couple of support groups shared their pictures and stories about the journey with Parkinson's disease within their local library, as well as inviting family and friends to a showing of their support group pictures. And they seem to really enjoy doing that. Another example would be that I, of course, have shared the pictures and stories with my nursing students, hoping to bring about more awareness of how Parkinson's disease affects the person and their family in their everyday journey. And through this process, hopefully create the change that can positively affect the health outcomes for the families. I met with each support group 3 times. The first time was to go over the project, give them information, answer questions, as well as go over the consent form. The second meeting was to check in and see how things were going. I purposefully did not attend the meetings as they were talking and sharing their pictures and stories, as I felt that the groups had a solid base and trust level, and felt that being an outsider might influence their sharing in a different way. The third meeting I attended was to discuss the whole process and administer a survey on how they felt PhotoVoice impacted their discussion and whether they felt it was useful or not. When I worked with the support groups, I gave them direction on what to take pictures of, as you could see in this slide. The directives included: take pictures of things that you do to help you cope with Parkinson's disease, take pictures of your biggest challenges that you face, take pictures of your support system, your resources, and while you can't change the diagnoses, take pictures of what your hopes and dreams are. These questions actually came from the work I did with the care partners themselves. One directive was given each month, as most support groups met monthly. So because of the length between meetings and the participants' concerns with their memory, I developed a worksheet to go with the picture-taking process. So here's an example of a picture and a story in regards to the challenges. One participant shared, accepting that my body can not do some of the things I used to enjoy, like running and tennis, and feeling like my mind doesn't work like it used to. This all affects my relationship with my family and my friends. While I don't have the pictures in this presentation, another example is a participant took a picture of a phone, stating, I oftentimes lose my voice when attempting to speak. This is especially difficult on the telephone. I have a hard time being heard and speaking clearly, so I don't use the telephone as much as I did in the past. I love to talk with family and friends, and now it is so difficult, I just give up. Another participant shared a picture of a tree to describe how she copes. Parkinson's disease is certainly a challenge which we experience every day. I find that I can cope by experiencing God's creation through watching the trees and seeing how they support the leaves, which represents how God supports my life. I try to meet my challenges by being with others, by recognizing that I'm not alone, and by sharing resources with each other. Through this process, many participants shared how they learned more about each other and were able to share experiences that they enjoy. In one support group, a participant found someone in their group who liked to play cards, and now they play cards together on a regular basis. In another support group, one participant shared how he was in a band and loved to play music. So they had a party and had his band come and play for their party. And they felt that these were things that they may not have learned about each other without the use of PhotoVoice. A survey was administered at the end of the project within each support group to see if utilizing PhotoVoice was an effective tool to bring about more discussion. A total of 82 evaluations were completed. And again, many of the couples completed them together. And as you can see, 88% found that PhotoVoice was helpful in bringing about more discussion within the groups. 80% felt that taking the pictures and writing down their feelings about the pictures helped them to explore more about Parkinson's disease and how it affects them in their lives. 94% stated that they found it was helpful to have others share their pictures and stories about their experiences. So while overall PhotoVoice did seem to help facilitate more in-depth discussion, it was also noted to be difficult for those who had Parkinson's disease to take the pictures and sometimes to even share their stories, depending on their stage within the disease process. Some of the comments from the participants regarding the use of PhotoVoice included, I got to know my support group at a different, deeper level. It was good. It brought about more discussion and a better understanding of each other. The pictures offered an opportunity to talk more in depth about some of our challenges and things that are harder to talk about. This project offered some time for good self-reflection. It made me think about how Parkinson's affects my life. And for me, one of the highlights and truly what I believe was one of the best things that came out of this project was the following statement. It was a good project to do together as husband and wife. While he couldn't take the pictures, he told me what he wanted me to take the pictures of. It helped us to talk about things we might not have talked about. So the literature reviews that I've completed while working with PhotoVoice support the need to tailor our interventions for the individuals that we're working with. And as we know, effective interventions are needed to improve the health and well-being of all the populations that we work with, specifically focusing on Parkinson's disease. PhotoVoice offers a unique, creative way to give people a chance to share their story with someone else. We know, a picture says 1,000 words. A picture takes you to a moment in time and brings emotion to the forefront. I'm guessing that everyone who's listening to this webinar has a picture in their wallet or purse of something that means a lot to them or someone. So take it out, share it with someone else. And how does that make you feel? You know, as I talk to the participants and all of the research I've been doing with PhotoVoice, every single person states that if their story makes a difference for someone else, they want it to be a part of it. Families who are living with Parkinson's disease are my heroes. I know what my parents went through. I know what I went through as I became one of my father's caregivers in this journey. Being able to share that journey with others who are experiencing all the same things is so beneficial, and offering creative ways to give voice to those experiencing Parkinson's offers opportunities for healing as well. So thank you for this opportunity to share what I've learned, and have a wonderful day. And we certainly will take questions. And here is the resource slide for more information about PhotoVoice.
Thank you very much, Joyce. That's very interesting, and you have really done a lot of work in this area. And I know you mentioned that the technique's been around for a long time, but I don't think I had ever heard about it until you introduced me to it. And you certainly have made an impact on the lives of support group members that you worked with through your work there. At this time, we're open for questions and answers for both speakers, for both Julie and Joyce. Please note that questions can be submitted by clicking in the text messaging box in the bottom left corner. Just type in your question and then hit the send button. So at this point, we'll start with our questions, and we have some that have come in already. Joyce, for you, I thought it was very interesting that the last comment where the person with Parkinson's couldn't take the picture, but it really opened up the dialogue with the care partner. So thinking about that, what are the areas that you've identified that could particularly help care partners in addition to opening up discussions? Did you find that it had any impact on their stress level, their burden, their caregiving issues?
You know, in the end, I don't know if it did, but what I do know is that it absolutely gave them opportunities for reflecting, for feeling like they're being listened to, and for talking about things that are really difficult to talk about. One of the most interesting things I found when I worked with the care partners was a gentleman who was 85 years old, and he was his wife's caregiver or care partner. And he took a picture of their bed, and he talked about how difficult it was to have sex with his wife because he ultimately, of course, was her caregiver. And with the medication that she was taking, it increased her sexual desires or appetite, so to speak. And he said he'd never had a chance to talk about this. So taking the picture gave him some freedom to do that. And then by taking that information and sharing that information with healthcare providers, it also opened up another avenue to give information to the healthcare providers on how we need to address some of these other issues that are more difficult to talk about. So I think in the end, what it did for a lot of the care partners that I worked with, and even in the groups themselves, was to just give them an opportunity to look at things that you wouldn't necessarily talk about if someone just asked you the question.
Very interesting. And it reminds me of the work that Julie has done with her caregiving and the loss of mutuality as the disease progresses, how what used to be a marital relationship, once there is a lot of caregiving involved, that dynamic can change. Julie, would you like to comment on that?
I was just thinking about that idea. What we know is that mutuality declines as the disease progresses, but there's been a little work trying to see if we can improve mutuality in later stage disease. And this might be a really interesting intervention that might be an interesting measurement to use in looking at this intervention. I'm not sure it's been done, but I think that would be very useful.
Okay. We have a question from California. It's a question for Joyce. Have PhotoVoice and pictures been used as a means of reflection following the death of the patient? If so, do you know what benefits it might have?
And I would say that I haven't seen any literature out there that has worked with PhotoVoice in that situation. And I think it would be a wonderful tool. I actually am going to do some work for this fall in regards to using PhotoVoice to heal the heart. So I'm actually going to do that research, working with people who have lost partners, and not necessarily just specific to Parkinson's disease, but who've lost partners and what they've utilized to help them through that process and how that might help others as they're grieving.
Oh, we certainly wish you luck with it and the good wishes with that research. It sounds very interesting. A question for Julie. How can one find out more about the Stanford process of chronic disease self-management? And along with that, are there other programs or workshops that we can recommend to caregivers on caregiver strain and us as well as people with Parkinson's disease?
So if you just Google Stanford chronic disease self-management program. They have a whole website. They're also almost every state has a variety of these chronic disease self-management courses being offered, and they're generic, so they're not specifically for one disease. So that's so Strive to Thrive. Ours was designed only for Parkinson's disease. So the research that's been done has been across all diseases, and when I talked to Kate Lorick, who started this, she said that there are many, many people with Parkinson's disease and their spouses, so it's not just always a couple, who have taken it and have shown benefit. So they haven't really culled out specific diseases because their goal is to really think about these strategies in a generic way. I think the other thing that I would bring up is that a specific caregiver program that has been as a takeoff of self-management is the Powerful Tools for Caregivers, and this is a 6-week course for family caregivers, and it teaches them self-management skills. It's available, I think, in 37 states and Canada. And if you just Google Powerful Tools for Caregivers.org, I think it's all one word, Powerful Tools for Caregivers, you can see a website that lists locations and ongoing classes. Again, it's a train-the-trainer model, so it's been perpetuated for years now.
Thank you very much. Also, I think we have Kate Lorick's article, or at least one of them, on your slide which showed us your selected references.
Right.
Okay, we have time for one or two more questions. We have a question for Joyce. Joyce, this is from a nurse in Illinois. We often work with patients in reminiscing therapy. What is the difference between reminiscent therapy and PhotoVoice?
Well, I've done a little bit of work with reminiscent therapy as well as storytelling, which is generally focusing more on their stories, the background information, just bringing some of that to the forefront. As we know, for a lot of people, long-term memory is more present, and so that brings about some good discussion and connection. PhotoVoice is very specific in the sense that it's actually working with the pictures, where they take the pictures and then talk about why they took that picture and what it means to them. Reminiscent therapy, from my understanding, is based on maybe a picture, for instance, that they have of someone that they love, or a background, their farms, or whatever it might be, and having them tell the story about that. So they're very similar, and I think could be very useful in many ways.
And it's not that PhotoVoice has the kind of added aspect that it gets a little bit of discussion going on. Why did they take this picture? What does it mean? Not just, here's my picture and let me tell you the story about why this happened or this occurrence. So it could be explored that way, right? All right.
Yes, thank you.
Mm-hmm. Question for Julie. Julie, for those of us that are clinicians, sometimes we're very busy in the clinic, and while we want to address the caregivers, sometimes time is a factor. Do you have any suggestions for streamlining the assessment of caregivers?
I actually do. First of all, I want to say that sometimes it's important to recognize as a clinician that just being present, acknowledging somebody and really truly listening to them is so therapeutic in itself. So we all have limitations of time and energy and all kinds of things. So that in itself, you are a very therapeutic tool just by being who you are. Short of that, I guess I have a couple of ideas. One is there's a website. It's by the National Hospital Association. The website is nextstepincare.org. So that's all one word, nextstepincare.org. And this is a really terrific website. And there's on the left-hand side of this website, there's different categories for different populations, like for family caregivers. There are a lot of resources, but there's also a resource for healthcare providers, and it's a toolbox basically to help assess family caregivers. And there are three questionnaires, all of them quite short, but incredibly useful if you don't have time to really do a lot of assessment. One is just availability and other resources. So it brings out some of those things I mentioned about health and gender and whether how many hours a day you're caring and those sort of facts about a caregiver. There's another one. There are three actually. So that one, and then there's a questionnaire that is about what worries you, and the caregiver fills this out. The beauty of that is that you're really achieving sort of caregiver-centered goals, and what worries you can really help direct you to what the caregiver needs. And the third questionnaire is, what training do you need to help your family member? And they have three options. One is that they can do this without training. The second one is they could do it with training. And the third one speaks to that value, that they can't do it, or they won't do it, or couldn't do it, which basically means that even with all the training in the world, it's not something that they are inclined to do. So that's one idea. I'll mention one other thing. Rosalind Carter, many of you may know, has taken a very special interest in caregivers, and she set up an institute, and it's rosalindcarter.org, and in that website, there's a large sort of there's all the instruments to measure. Anything you ever wanted to measure are in that website. So if you had one specific thing like grief you wanted to measure, she has really brought together all the effective tools and their psychometrics, and you can just visit that and really see what would be helpful in your own practice to measure.
Thank you very much. Very interesting. Good. We have a question for Joyce from Indiana Joyce. Do you know of any models or methodology that incorporates music along with pictures as a tool?
No, I don't, but that sounds awesome. Go for it.
I think it's a very interesting question. I don't know the answer to that either. I don't know, Julie, if you know of anything like that.
I don't know. That's interesting.
Yeah. We do have a couple scholars who have been busy working on music interventions, so perhaps at some point they'll be able to share their information with us at another time.
One idea might be to visit the music therapy. There's a music, and you may be part of this, whoever's asking the question, but I know in New York there's a school for music therapy in a variety of places, and maybe they would, and they've done a lot of research, and that might be a place to ask that question.
I think Music in the Brain program or institute or something. I forget the name of it, but something like that. Good. So this has been really a wonderful discussion and two wonderful presentations by our experts. Thank you both, Julie and Joyce, for your time today and sharing your work with us. While we were doing some questions and answers, there was a slide that came up on additional trainings offered by the Parkinson's Foundation. and also some additional resources. So they are certainly available to our listeners to go back to and to view.